Myself Dr. TRIVEDI, Assistant Professor in the Department of Physiotherapy and Paramedical Sciences. Today we are here to discuss the topic principles of orthosis in rehabilitation. Orthosis is a orthopedic appliance or apparatus used to support, align, prevent or correct deformities or to improve function of movable parts of the body. Orthosis purpose is to lend stability to a weak joint, correct or maintain alignment, correct skeletal deformities, etc. Further we discuss principles in designing orthosis. There is 3-point pressure system, total contact system and partial weight relieving system through which orthosis is designed. First, we discuss 3-point pressure system. That is, the sum of the forces and the bending moment created is equal to 0. That means a single force is placed at the area of deformity, two additional counter force act in the opposite direction. During quiet standing line of gravity, weight line passes through posterior to hip joint, anterior to knee joint and anterior to ankle joint. That is the diagram of 3-point pressure system. Next, total contact. Pressure is equal to the total force per unit area. The greater the area of the pad of an orthosis, the less force will be placed on the thing. That means P is equal to force upon area of application. This is the formula for the total contact pressure. Now, partial weight relieving system. The further the point of force from the joint, the greater the moment arm and the smaller the magnitude of force required to produce a given torque at the joint. The greater the length of the supporting orthotic structure, the greater the moment or torque that can be placed on the joint or unstable segment. Now, type of orthosis. There are 2 types of orthosis: upper limb orthosis and lower limb orthosis. First, in upper limb orthosis, we discuss about figure of 8 axilla wrap. Common name is clavicle strap brace. Objective of this orthosis is to retract the scapula. First, to apply pressure to the axilla to prevent or correct hypertrophic scar, to maintain and restore shoulder mobility, to stretch contracted tissue around anterior chest, and to prevent and correct kyphotic posture. Second one is gunslinger splint. Other name is elbow wrist orthosis. Common name is shoulder gunslinger splint. Objective of this orthosis is to fully immobilize the shoulder and sometimes elbow to promote healing. The elbow and wrist are immobilized to maintain full control on shoulder. Next one is airplane splint. Common name is axilla oblique airplane splint oblique conformer. Objective of this splint is to elevate hand and prevent edema. Second one is to prevent and reduce an axilla contracture. Third one is to maintain and restore shoulder mobility. Fourth one is to immobilize upper extremity after skin grafting. Fifth, to apply pressure to prevent or reduce hypertrophic scarring. Now, splints used for elbow. First, posterior elbow splint. Common name is posterior elbow splint. Objective of this splint is to support and rest elbow to relieve pain. Second one is to immobilize elbow to relieve pain. Third one is to block elbow extension. Indication of this posterior elbow splint is rheumatoid arthritis, elbow surgeries, etc. Next one is anterior static elbow splint. Objective of this splint is to prevent or correct elbow flexion contracture. Second one, to block elbow flexion. Indication of this splint is in burn, ulnar nerve entrapment, capsular tightness, elbow surgeries like tricep rupture, tumor resection, total elbow arthroplasty. Next one is tennis elbow strap. Objective of this orthosis is to reduce pain and inflammation. Indications of this orthosis is inflammation of common tendon origin. Next one is Cockle splint. This is a very well-known orthosis which is used nowadays. It is aesthetic in nature. Common name is volar palmar wrist splint. Second one is volar wrist Cockle splint. Third one is wrist immobilization splint. Fourth one is drop wrist splint. Fifth one is carpal tunnel splint. Sixth one is wrist extension immobilization splint. Seventh is work splint. Eighth is ulnar gutter splint. And ninth one is radial gutter splint. This is all the common names of Cockle splint. Objective of this splint is to reduce pain and inflammation. Second, to protect against joint damage. Third one is to promote hand function. Fourth one is to prevent or correct contracture. Fifth one is to provide base for outriggers points. Indication of this orthosis is used in tendinitis, oblique tendinosynovitis of wrist tendons. Second one is joint inflammation. Third one is skin grafting, unstable wrist joint, wrist sprain, paralyzed wrist extensor, congenital hand deformity, volar stiff flexion outriggers, dorsal stiff extension outriggers. Now, dynamic wrist extension splint. Objective of this splint is to passively extend the wrist while allowing active wrist flexion to prevent contracture of unopposed innervated wrist flexors. Indication of this splint is in weak or paralyzed wrist extensors, for example, radial nerve palsy. Now, we discuss about hand, finger, thumb based orthosis. First one in this, metacarpal fracture brace. Common name of this orthosis is metacarpal fracture brace. Objective of this brace is to stabilize metacarpal fracture to promote healing. Indication are mid-shaft fracture of third, fourth or fifth metacarpal. Now, ulnar deviation splint. Surgical release of depressed contracture to maintain surgical gain extension, increasing muscle tightness and extension contracture, and metacarpal head fracture for stabilization. Final fracture splint. Common name of this splint is final fracture splint. Objective of this splint is to progressive flexion MCP-IP in composite flexion, applying gentle prolonged stretch to contracted tissue. Indication of this splint in contracture of extrinsic extension tendon, IP extension contracture. This is the structure of this splint. Next one is dynamic thumb opposition strap. Circumferential wrist base dynamic thumb opposition strap. Common name is dynamic thumb opposition splint, thumb abduction splint. Indication and objective are weakness and paralysis of the inner muscle, adducted thumb position associated with thigh bone, position thumb in palmar abduction to facilitate opposition, to place thumb in radial abduction to break up flexors. Next one is dynamic thumb opposition strap, made of perforated comforter for cool comforter wear. Recent advances of this orthosis is in their study shows use of dynamic orthosis over static orthosis. It provides definite amount of function to the limb as well as support, whereas the static orthosis provides support but function ignored. Second one is Mike S. McGrath et al. In this study shows that use of a static progressive splint in increasing nowadays using a static splint for whole day give rise to other complications, whereas these splints help to improve restricted motion, promote support, enhance mobility with minimizing stress. Third one is use of upper limb exoskeletal over dynamic splint help to enhance body function of individual in targeted form without ending complications of splinting. Now cervical orthosis. First one in this orthosis is soft cervical collar. This is very common orthosis which is used in cervical region. A cervical collar, also known as a neck brace, is designed to stabilize and support the cervical spine in a neutral position, while limited head movement to help immobilize the cervical spine. Used by emergency personnel for traumatic neck or head injuries. It can also be utilized therapeutically to help relieve pain by realigning the spinal cord of strain or whiplash injury. Second one is cervical orthosis. Collars are soft or semi-rigid which provide minimal motion control. Most common type is Philadelphia collar which has mandibular and occipital extension and rigid anterior struts. Used for upper cervical injury and fracture. Second one is for post cervical orthosis. It gives moderate control of motion. It has two anterior and two posterior uprights. Two anterior upright connect sternal and mandibular plate. Two posterior upright connect thoracic and occipital plate. Next one is Minerva orthosis. For maximum control of movement, Minerva orthosis or halo orthosis, it is non-invasive appliance that has rigid plastic posterior section extending from head to mid-trunk. The superior portion is held in place by forehead band, is used for cervical fracture for healing. Now spinal orthosis. First is corset. If abdominal compression is the basic goal, a corset will suffice. It provides vertical reinforcement. It covers lumbar and sacral areas. The biomechanics of corset is to increase intra-abdominal pressure, which will in turn reduce stress on intervertebral disc. This will thus reduce frontal movement. Second one is lumbosacral flexion, extension, lateral control orthosis. This is all about the structure of this orthosis. It is rigid trunk orthosis. It is also called night spinal orthosis, which is most common orthosis used in back pain, for back pain. This includes a pelvic band which provides anchorage over the midsection of the buttock and a thoracic band intended horizontal over lower thorax without impingement of scapula. Biomechanically, it follows the three-point pressure system. Posterior pressure is applied from back, upper, bottom side, and anterior pressure from abdominal aspect. Lateral aspect to control lateral flexion. Next one is stellar brace. This is also most common brace which is used in back pain. It is also called thoracic lumbar flexion extension control. Indications are controlling back pain by limiting motion and unloading disc, vertebral and other spinal structure by compressing the abdomina. Second one is stabilizing weak or injured structure by immobilizing the spine. Third one is providing 3.4 system to provide correction or prevent progression of a deformity. Next one is condition like osteoporosis and post disease. More about Taylor brace. Biomechanically, it is used 3-point pressure, posterior force by axillary strap, the anterior force by midsection of the abdominal front, and anterior pressure from intrascapular region. Now, scoliosis brace. First one is Boston brace. The most commonly prescribed brace for scholarships today is the Boston brace. Many people know the Boston brace is a type of thoracic lumbar sacral orthosis, that is TLSO. Other type of Boston brace models to exist such as CTLSO, TLSO with a neck extension for a high thoracic curve, though they are not as common. The Boston brace works by applying corrective pressure on the convex side of the curve and cutting off corresponding area of relief on the concave side of the curve, so the spine can migrate in that direction. Now next one is Milwaukee brace. The Milwaukee brace, which is the original cervical thoracic lumbar sacral orthosis invented in the 1940s, is an older and bulkier brace. Due to the effectiveness and relative convenience of today's more modern braces, the Milwaukee brace is rarely used anymore. However, it is still sometimes used for curves higher in the thoracic and cervical spine. It's all about structure of the Milwaukee brace. Now, Wilmington brace, another common name is thoracolumbar sacral orthosis, is the Wilmington brace. Another name is Wilmington brace. This brace goes onto the body similar to a tight jacket and is known as a full contact TLSO due to its lack of gaps or open spots. Now, lower limb orthosis. First, we discuss function and comfort of lower limb orthosis. First point is to discuss to meet individual mobility needs, maximum stance space stability, minimizes abnormal alignment, minimally compromises swing clearance. Last one is effectively reposition limb for initial contact. Comfort can be worn for long periods and can be on and off easily. Consideration gait, stance phase in adequate transition, swing phase, toe drag, circumflexion, hip hiking. Anatomical causes, weak plantar flexors, force foot pain. Anatomical cause, weak dorsiflexors, spastic plantar flexors, weak hip flexors, weak dorsiflexors, short contralateral lower extremity, hip flexion contracture, hip flexor weakness, and weak dorsiflexors. Now, examination. Points to be assessed while prescribing orthosis. First one is joint mobility, limb length, muscle function, sensation, upper limb strength, psychological status, special lifestyle consideration. Shoe in foot orthosis, components of lower part of shoe. Sole, it is a part of shoe in contact with ground. The inner part of sole against which the foot rests is called insole. Bars, straps and wedges which common attachment to the foot orthosis get their leverage and attachment through the sole and exert their forces. Second one is ball, widest part of the sole that is located in the region of the metatarsal head. Third one is shank, is the narrowest part of the sole between the heel and ball. The upright of the AFO attach themselves to a stirrup at the shank region. Fourth one is toe spring. It is the space between the outer sole and the floor, which helps to produce a rocker effect during toe or phase of gait cycle. If a lift is added to sole, it composes LLD. Heel is the posterior part of the sole which corresponds to the heel of the foot. Since it is the portion where most of the body weight is taken, it needs to be resilient and thicker so that it can prevent shoe components from wearing out and shift weight to the forefoot. Upper part components are, first one is quarter. This is the structure of shoe modification. Toe box, upper and lacing, outsole, foxing, midsole, and it is shoe counter. Modification of shoe conditions are for limb shortening, arthritis, instability of subtalar joint. Objective are provide symmetric posture modification are heel and sole elevation. First, arthritis. Objective of this modification of shoe is to improve gait and support and limit joint movement. Modification of the shoe modification is high corner shoe, reinforced heel corner, long steel shank rocker bar. Pes planus valgus, reduce eversion support longitudinal arch. For children, high quarter shoe with broad heel, long medial counter, medial heel wedge. Pes provide heel strike content foot in shoe, reduce pressure on metatarsal head, equalize leg length. High quarter shoe, heel lift and metatarsal parts or bars, heel and sole elevation on other shoe according to LLD. Pes varus, realignment for flexor deformity and accommodate fixed deformity, increase medial and posterior weight bearing. High quarter shoe, high to box, lateral sole, heel wedges and medial wedges for fixed deformity. These all are the modification of shoes. This is all also the conditions in which we modify shoe. Now AFO is a boot to which an ankle joint is fixed through this tie. The metal uprights are ascending up to the calf region. Components of this ankle foot orthosis are proximal calf band with the lateral strips, median and lateral bars. Median and lateral support can be given, and there are five types of artificial ankle attached to foot orthosis. First, free ankle. Second is limited ankle joint. Third is 90-degree foot drop stop. Fourth one is reverse 90-degree ankle joint. Now, indication of AFO is dorsiflexor muscle paralysis. Aim is to prevent contracture of the Achilles tendon and to assist dorsiflexion during heel strike, or dorsiflexion assist plastic posterior leaf AFO can be prescribed that can be inserted in shoes for easy foot flight without undue knee flexion. Ankle and foot paralysis is prescribed to provide stability and reduce gait revision during the swing and stance phase. Spasticity. AFO are used in children with cerebral palsy to stabilize the foot during the heel stroke and foot flight phase. Fourth one is limited weight bearing. This is rare indication of AFO. Now, anterior flow reaction ankle foot orthosis. Patellar tendon bearing orthosis. As the name suggests, the weight is relieved in middle and distal tibial heel and foot. Indications are unstable fracture of pelvic ring, fracture of acetabular with minimal displacement, fracture of femur, complicated fracture, comminuted fracture of tibial plateau, 6-1 is tibial plateau fracture. KFO, this is the structure of KFO. Components are same as AFO. In addition to this, there is a upright extended from knee joint to the thigh. Thigh bend can suspension mechanism to which uprights are attached. Knee joints are provided so wearer can sit and keep a good gait pattern to avoid stiff knee gait pattern. Straight set knee joint allows free flexion and prevent hyperextension. Upper segment rotates in single transverse axis. It is used in combination with drop lock to give stability. It is cheap and easier to repair. This is all about KFO. Posterior, this is all the parts which is used in KFO. Polycentric knee joint, posterior offset knee joint, stance control. Now, this is the types of orthotic knee joints. This is the condition in which KFO is used. Genovarum valgum, problem in load bearing, and knee braces prescribed in severe osteoarthritis. Now, HKFO, it is extension to KFO. Its hip extension is to provide hip flexion and extension. Uses are weak muscle controlling hip and can be possibly weak knee and ankle. Types of HKFO are bilateral HKFO, unilateral double upright HKFO, bilateral double upright HKFO. HK4 indications are to assess gait, decrease weight, control movements, minimize progression of movement. Now this is all about physical therapy intervention of upper limb and lower limb orthosis. This is lower limb orthosis. It's all about AF4. AF4 are commonly prescribed for weakness of ankle dorsiflexors, plantar flexors, inverters and inverters. AF4s improve gait revisions by taking advantage of ground reaction force, such as controlling the progression of the tibia over the ankle and limiting knee flexion and extension during stance. An AF4 can also assist free swing phase. KF4 and KF5 extend the AF4 to control the knee, quadriceps weakness, below anti-gravity, strength or knee hyperextension, not controlled by an F4, are indication for a KF4. Knee orthosis provides support or control of knee joint. Knee orthosis can limit motion in the sagittal, axial or coronal planes. Generally, knee orthosis are prescribed to prevent knee hyperextension and provide medial lateral stability. Hip orthoses are indicated for accelerated acetabular problem and are commonly used for post-operative care, hip dislocation, dysplasia and injury. HK4 are typically used in patients with spinal cord injury to stabilize the entire lower limb in order to stand and walk with assistive devices. Thank you. This is all about orthosis, in which we discuss about upper limb orthosis and lower limb orthosis, types, condition and indication, contraindication, which is used in physiotherapy for rehabilitation of patient with different conditions.